We're here today to talk about left main disease, and I'm joined by three luminaries, of course, S.J. Park, Whan Lee, and world-famous surgeon Dr. David Taggart. So let me give you a quick overview of where we are with left main disease, and I'm going to summarize this very quickly. We're going to go over what the guidelines are today based on current randomized trial data we have, and look really at the upcoming trials, Excel and Noble, which we presented later in 2016, which are highly anticipated. And we'll also discuss quickly some of the ongoing issues with left main PCI, including the potential for BVS and DAP duration. So I think right now cardiac surgery is the accepted gold standard for basically all forms of left main revascularization requirements. Class 1 in the guidelines in 2004 from the ESC EACS with level of evidence B, reflecting the fact that there really are only two small randomized trials of left main PCI versus medical therapy, but nonetheless they were very compelling. On the other hand, the ESC does have a similar level of recommendation for PCI for patients with a syntax score of less than or equal to 22 and unprotected left main disease. So basically left main disease and very little else, mostly single or simple double vessel disease. A 2A recommendation for the intermediate complexity patients with a syntax score of 23 to 32, and class 3 indicating either harm or should not be done for patients with complex multivessel disease as well as left main disease. The 2014 ACC-AHA Stable Ischemic Heart Disease Guidelines, looking at unprotected left main revascularization for survival, notes that the CABG is once again class 1, level of evidence B, and PCI does not have a class 1 indication, but ranges from either class 2A to class 3, depending on the associated severity of concomitant coronary artery disease. And that's also reflected in the appropriateness use criteria with multivessel revascularization in patients with left main disease, where it's either appropriate or uncertain or inappropriate, again, basically depending on the complexity of concomitant coronary artery disease. But even the best trial to date, which is the syntax trial, was not powered to look at left main coronary disease, and so we don't have one definitive trial which really can guide PCI compared to bypass surgery. So this is the syntax trial, left main disease with 705 patients of the 1,800 randomized patients, and this was again CABG versus Taxus stenting. Overall, the primary quadruple endpoint of death, MI, stroke, or unplanned repeat revascularization was not significantly different between bypass surgery or Taxus. And any small difference was really driven by repeat revascularization. But it really did depend on the underlying syntax score, such that for the low and intermediate syntax scores, PCI in this subset of analysis seemed to be a good alternative to CABG, whereas in the high syntax score patients, there was a mortality advantage and multiple other advantages of bypass surgery. So that really has led to the hypothesis for the ongoing studies. SJ ran the PRECOMBAT trial in the CIPHER era looking at PCI versus CABG, and for death, MI, stroke, or repeat revascularization with follow-up to 5 years. In that trial, did not find a significant difference. There's a new meta-analysis which has been presented recently at TCT Asia Pacific, looking at now a patient-level meta-analysis from the BEST trial. This was bypass surgery versus everolimus-eluting stents, and then PRECOMBAT with CIPHER and syntax trial with Taxus. So overall, a very large meta-analysis of 1,300, over 3,000 patients, and looking at arguably the important endpoint of death, MI, stroke, which I think we would all agree are the three most important components that we could track. There was no significant difference at all between PCI and CABG. But again, this is still all in the hypothesis generating phase. So we'll have two trials that will be presented later this year, which I think are going to give us important guidance as to how to treat these patients. The Excel trial enrolled patients with a syntax score of up to 32, and then randomized them 1-to-1 to a really contemporary state-of-the-art metallic drug-eluting stent, that is the Xience everolimus-eluting stent, or bypass surgery with contemporary surgical techniques. Dr. Taggart was involved in the design of that trial. This was designed by a 50% group of interventionalists, 50% surgeons, so it's really meant to reflect best contemporary therapies. We actually randomized a total of 1,905 patients. We changed the sample size to complete the study, and the primary endpoint were powered for death MI or stroke at a median follow-up of 3 years. And we're on track to present this trial at TCT later this year. The NOBLE trial, a NOBLE study, which was done primarily in the UK, enrolled 1,200 patients with left main disease and simple concomitant coronary artery disease with up to 3 lesions and without other complex coronary lesions, and randomized them 1-to-1 to either PCI or CABG, and the preferred stent in this trial was the Biomatrix Biolimus A9 drug-eluting stent. And the primary endpoint was death, stroke, or non-index treatment-related myocardial infarction, or the need for new repeat revascularization during follow-up. And this we believe will also be presented during TCT in the same session this year in a late-breaking trial session. So we'll have a coordinated session. We'll have deep dive additional sessions. So it should be very, very exciting. So before we get on to the newer areas, perhaps we'll stop at this point and we can have a discussion of where we are with PCI versus surgery for repeat revascularization. So SJ, let me start with you. I think Asan Medical Center probably has the world's largest experience of left main PCI. And your studies have been really seminal in helping to move this field forward. So maybe you can give us your insights into how technique evolution and stent evolution over the years has affected the outcomes of PCI for left main revascularization.
In terms of efficacy concerns, PCI versus surgery for left main disease, actually from the almost more than 10 years, the data clearly demonstrate actually no difference in the hard endpoint. It's a death MI or death MI stroke, and only difference in a target vessel, target lesion revascularization. And so I think main disease is basically totally different with the multi-vessel disease concept in terms of efficacy concern with the PCI versus surgery. Mm-hmm. And even in the era of first generation of drug-eluting stent, still better outcome. Syntax and main subset is clearly demonstrating no difference, as our PRECOMBAT study no difference. And so Excel studies will give us a final answer maybe in the next TCT meeting. And before that, actually, Dr. Lee get the patient level, merge the meta-analysis, including the syntax and PRECOMBAT and best trial. And so Dr. Lee will give some...
So Dr. Lee, tell us about this new meta-analysis and what the findings were.
Okay, so as everybody knows, most RCT have limited power to assess hard clinical outcome. So we combine database from the best PRECOMBAT syntax trial. Total number of patients more than 3,000. Primary outcome was composite of death MI stroke. And we found there was a significant 17% risk reduction of primary outcome in CABG group compared with the PCI group. However, there was a significant interaction between treatment effect and type of disease. So in cases of left main disease, absolutely no difference between the two groups. But in patients with the multi-vessel disease group, there was a huge difference. It's risk reduction roughly 1/3. So in patients with the multi-vessel disease, definitely favors bypass surgery. But the left main disease, no difference between the two groups.
So David, let me ask you, this is really interesting. Going into syntax, I think everybody expected perhaps drug-eluting stents would match surgery for multi-vessel disease, but we were much more concerned about left main disease. And if anything, this has all been flipped on its head, where I guess it makes sense when you think about it. The left main is a short focal lesion in a large vessel. It should respond well to a good drug-eluting stent versus long, diffuse, complex multi-vessel disease. Your insights?
Well, I mean, I think that's a great summary. I mean, until relatively recently, 5 years ago, our philosophy was that for most patients with multi-vessel disease, they should be treated with PCI, and as you've said, not to touch left main. And the results of syntax have turned that on its head, where we now see a clear blue water between patients with multi-vessel disease who do better with cabbage, as opposed to left main, where PCI produces at least equivalent results. And there may be cohorts of patients with left main where in fact PCI becomes the gold standard treatment.
Right.
But I would be cautious about how we interpret data, particularly your meta-analysis. I think there are three critical things we must know before we interpret any data. The first is, who were the patients in the trial? Secondly, what is the duration of follow-up? And third, did the cabbage patients receive guideline-based medical therapy? So for example, in your meta-analysis, if we look at COMBAT or BEST, the mean syntax score of these patients was 24. So they would have been towards the lower cohort of the syntax trial, and therefore the results you have from those are entirely consistent with syntax trial. The second thing is duration of follow-up. We must have at least 5 years, and to your credit, you've done that with your studies, because if you look at syntax and freedom, the results at 5 years in favour of cabbage were very different what we saw at 1 to 2 years, where there seemed to be no difference. And the third thing is, as shown by the syntax investigators again, and as shown in your PRECOMBAT and BEST trials, the cabbage patients consistently receive inferior optimal medical therapy. And syntax showed that that impacts adversely, both in terms of mortality and MACE. So to me, the three things I want to know before I critically analyze data is, who were the patients in the trial? And if we have no syntax scores, we have no idea of a population. And to your credit in Excel, this is one of the things, you had a parallel registry, as syntax did. So from Excel, we will be able to really work out what is the best strategies for different types of patients. And also, to your credit in Excel, was you were the first person to insist that cabbage patients must also receive optimal medical therapy. No one else had done that. So those are the way I'm looking at things just now.
Very good. Would you like to comment on maybe the differences in the patients and their follow-up and the medical therapies in the three component studies of the meta-analysis?
Yeah, I agree with you. So I'm so surprised that patient receiving the bypass surgery significantly less used the optimal medical therapy. Why do you think that the surgeons are
so which
reluctant
medical
to
therapies
use?
also are you referring to? Are you referring to dual antiplatelet therapy, beta blockers, ACE inhibitors?
And
All
statins.
things used.
And statins.
But maybe I can turn the question back to you. You explained to me why in Korea. So in the BEST trial and PRECOMBAT, in your papers you actually say the cabbage patients receive substantially inferior medical therapy. So this seems to be universal. I don't think it's particular to Korea or Europe or North America. In Britain, we are very different because it's mandated by our government. We have special nurses who follow patients to ensure everyone is on optimal medical therapy. So that's not a problem in our country, but it does seem to be pretty widespread in other countries.
Is there any different data in the British? And you mentioned about full optimal medical treatment in the surgical side. It can make a little bit different with it.
Well, we haven't analysed the results specifically by that, but it'd be very interesting to see. But I think, as I said, Excel will be very important in helping us understand, does making sure cabbage patients are on optimal medical therapy, does that change their results even more favourably?
And let's hope they actually stayed on optimal medical therapy as recommended in the protocol.
Well, yes.
And
So
another interesting findings, if you focus on cabbage subgroup, so multivessel disease alone versus multivessel plus left main disease. Multivessel disease is the rate of primary outcome and all-cause death is significantly lower compared with left main plus multivessel disease. So if you analyze further detail, patient in multivessel plus left main disease group, patient receiving multiple graft, more than graft number more than 4, have a significant better, shows a clear trend toward better survival compared with the patient receiving pure graft in this particular group.
But I think what the most likely explanation for this is that if you have left main without additional proximal coronary artery disease, I think often there is just too much competitive flow for bypass grafts, and particularly for arterial conduits. Whereas if you have any type of left main plus functionally significant proximal three-vessel disease, this is where your bypass grafts are going to do best, and particularly bilateral internal mammary arteries.
It's also, though, where it leads to progression of the native coronary artery disease, which we show us all the time.
Yeah, so up to 2.5 years after bypass surgery, actually it's the curve parallel, no difference between multivessel alone versus multivessel plus left main disease. But 2.5 years after an index operation, the curve continue to separate, reaching to twofold. So,
well, I think this is very important. Indeed, if you look at the 5-year mortality in syntax overall, where there's a significant benefit of CABG, at 5 years, those survival curves are actively diverging. In the FREEDOM trial in patients with diabetes, they're actively diverging. And if you look at the large propensity match registries, there's this consistent theme of separating survival curves. So you could, in fact, say that even at 5 years, it's too early to judge the true efficacy of each of these interventions.
Well, we'll see. I mean, this is where I do think that the different stents will make a difference. And I am a little surprised that you found no interaction with stent type, because we've seen in all the numerous studies that, everolimus-eluting stents compared to paclitaxel-eluting stents in particular have much lower rates of stent thrombosis, myocardial infarction, and even mortality. So, I mean, Syntax had a 10% mortality, a 10% stent thrombosis rate at 5 years. That's extraordinary. 10% stent thrombosis. 1 out of 10 patients having stent thrombosis.
But David, what about the focusing on the main disease, right? You just concerned about this, multivessel, including what about the main disease? I think it's a little bit different with the multivessel disease.
I agree, but I think if you have significant multivessel disease, the left main becomes almost irrelevant to bypass grafts. But I also have to disagree with you slightly, Greg. There is no question that the current generation of stents are far better than previous. But I don't think the benefits of bypass graft are to do with the type of stent. When you compare them, the benefits of bypass graft are protecting against future proximal disease, and also it's been very clearly shown by Tom Lucier 3 decades ago in the New England Journal of Medicine that the use of a mammary artery elutes nitric oxide into the distal coronary circulation and protects that endothelium. So this is why I think the improvements in each generation of stents have still not yet been able to match the results of bypass surgery.
Well, we'll see. You've seen the Stefan Windecker meta-analysis in 100,000 patients and 262,000 patient years of follow-up, which suggests that stent type does make a major difference, and that everolimus-eluting stents have pretty much caught up with bypass surgery. But that's a network meta-analysis. It's all of this. We can all find data on both sides of the fence. So that's why Excel and Noble, we have 3,100 new patients to look at, and I think will be very important.
But the network meta-analysis of Stefan Windecker, my conflict of interest is I was one of the co-authors of that.
So you believe everything in the paper, of course.
What I did point out was one of the problems with that network meta-analysis is the mean follow-up was 2.9 years. So we have 100,000 years of follow-up, but very little per patient. And the other thing is we have data now showing the patency of bilateral mammary arteries, angiographic patency, out at 20 years being over 90% for both mammary arteries. So bypass takes a very long view of what we're doing, not a 3-year follow-up.
Okay, so Dr. Lee, you got some subgroup analysis about the main disease status. Would you tell us some part of even better outcomes in case of PCI?
If you divide the patient into 2 groups, limited left main versus extensive left main. Limited left main means left main alone or left main plus 1 vessel disease. And extensive left main is left main plus multi-vessel disease. There is a significant interactions in terms of hard clinical outcome, including all-cause mortality. So limited left main disease favored PCI, but extensive left main disease, no differences between CABG and PCI. So if you look at CABG group, 5-year outcome, absolutely no difference between limited and left main disease in CABG group. But if you look at the stent group, significantly lower rate of 5-year mortality in limited group compared with
Well, and that's
extensive group.
similar to what was seen in syntax. In syntax, it seemed to go up to a syntax score of 32,
Yeah.
where the results were similar. In fact, in that subgroup of a subgroup, PCI had a mortality advantage
Yes.
out to 5 years. But again, we will see what the prospective data
We
shows.
didn't describe yet, however, even in the 30,000 patient rebel meta-analysis, is clearly demonstrate in the case of multivessel disease, big difference in terms of complete versus incomplete
yes,
revascularization,
yes.
right?
Yeah.
So main hard point, even in the meta-analysis, in case of a complete revascularization, in case of a syntax, our study, actually no difference at all in the hard endpoint concern.
Yes.
However, incomplete revascularization is big difference in terms of new region, revascularization, microinfarction, get together, that translate to the, hard endpoint, death NMI.
Yeah.
So,
yes, but I would say, as I said earlier, I think one of the difficulties with interpreting the data is that the vast majority of your patients, both in pre-combat and the BEST trial, had mean syntax scores of 24. So the lack of showing differences in these patients was similar to what we had already seen in the syntax trial when you break it into the terciles of low, intermediate, and high-risk patients.
So mean syntax of 24 is approximately half syntax, low syntax scores and half intermediate syntax scores. So that's exactly what's being tested in the cell. And that makes sense. I think it, when you go back now and you think about the syntax trial, the hubris that all the investigators had to think that you could deal with the types of patients that, frankly, we weren't treating with PCI before syntax. They put into the syntax trial. There was a belief that drug-eluting stents were going to be the end-all and cure-all for everything, which, of course, was very naive. So I think for PCI to be effective, we have to choose the right kind of patients. We have to not outstretch. Stents are good for limited focal disease. I think for diffuse extensive coronary disease, right now, bypass surgery remains supreme.
So the same, in case of ACC-AH guidelines, they mentioned about the unfavorable anatomy for PCI, right? That is exactly the same way. The feasibility concern is very important. If the region subset is very good, candidate for PCI, why not? We're going to do the, even in the multivessel disease, we can make a complete revascularization. The result should be good. So the personally, I think the feasibility is very important. Just you mentioned about diffuse disease, that we cannot make a complete revascularization. Why not? Send the patient to
that's what we have to understand more. I mean, this importance of complete revascularization, which seems more important after PCI than after CABG, is very important. And one of the reasons that high syntax score patients do poorly with PCI is that the likelihood of incomplete revascularization goes up. And so the residual syntax score, what we leave behind, goes up. And so the question is, certain operators, of course, can get complete revascularization more than other operators. It's a technique-dependent procedure. And so if you take a complex syntax score patient and can get complete revascularization with a high likelihood, what will be the outcome of that patient compared to a patient where you only had to put 2 or 3 stents in and get complete revascularization?
I mean, I think it's important, when we talk about incomplete revascularizations, there are 2 types. There's appropriate incomplete revascularization and there's inappropriate incomplete revascularization. And I think the difference between PCI and surgery is at bypass grafting, you would never leave an important vessel ungrafted. But in even the best PCI hands, for technical reasons, there may be vessels that you can't reopen or get a good result in. And that would then be inappropriate incomplete revascularization. Now, at operation, if we see a small vessel serving an infarcted area, we wouldn't graft it. But that's appropriate incomplete revascularization, and I think this is the difference.
So we're doing a very careful look at the completeness of revascularization for those 2 types, and also ischemic versus non-ischemic complete revascularization, not just anatomic, and I think that will be very revealing as well. So I think we are over time. I think it's less important for us to talk about some of the specific PCI technical issues. I think we will stop at this point, but I want to thank Drs. Park, Lee, and Taggart for a great discussion.
Thank you for having us.
Thank you.
Thank you very much.
Thank you.
Great.